Now, too much estrogen in the blood again gives you symptoms, and the too much estrogen will give you a number of symptoms. The spider nevus, the pectoral alopecia, the gynecomastia, altered hair distribution, power edema, and the cause of portal hypertension, the portal hypertension effect. See, esophageal varices, as you can see, splenomegaly, caput medusa, and ascites and legadema. The hyperthyroidism, bone marrow change, anemia, leukopenia, homocysteine. And this is the last slide, ladies and gentlemen. This is the neurological manifestation. And thank you very much for not putting your hair. Now, this is the last slide. This is stage 1. You get what? You get here, stare, Baker's stare, and perception. Stage 2, lethargic, flappy tremor, muscle twitching as a real failure. And the third stage, noisy, abusive, and violent. And this is the last stage where he cools down and sleeps in coma. Fetal hepatitis, knee and ankle clonus. Knee and ankle clonus is very important. And you get Babinski up, as if he has got the pyramidal sign. Babinski up, and the clonus is there. And you get some EE changes of stuff. And thank you very much, ladies and gentlemen. This is the lady looking forward for a better health. And to share in building a healthy community, we need to polish our knowledge periodically for better performance. And thank you very much. God bless you.
Thank you very much for polishing our
Thank you. Yes, 2 minutes. Good chap, he's our sponsor.
Yeah.
He's going to talk about glucovans. Glucovans is an excellent drug. I hate the glyburide, the glycomide, but in this combination with glucovine and the bioengineering of the capsule, I think it is working well. Well, I'm sorry for because we started late, ladies and gentlemen. That's my mistake. Okay. You were here at 8 o'clock, I was finished.
So good morning all of you. I assure you that it's a very brief presentation on glucovans for 5 to 6 minutes time, that's all. I'm sure that by now you all know what's glucovans. It's the first combination in the Gulf. It's a combination of metformin and glibenclamide in a very special way. These are the key concepts behind glucovans. Glucovans is not a regular drug, it's a drug manufactured with an advanced tablet technology, in other words, ATG. It is capable of treating both the problems, insulin resistance and insulin secretion in one tablet. It is effective in bringing down all the parameters of type 2 diabetes, controls fasting plasma, postprandial and HbA1c levels. And the specialty of this drug is that it causes less incidence of hypoglycemia and gastric disturbances with the best compliance rates. Straight away going to the advanced tablet technology, this is what makes this drug totally outstanding. This technology gives a new profile to glucovans. As what you can see, this is the structure of glucovans tablet. You can what we have used is a new type of metformin and a new type of glibenclamide. The scattered particles, what you can see here, are the glibenclamide particles. The specialty of this glibenclamide is that you have different particle sizes, small, medium, large, and very large particles. They are attached to the metformin, and the metformin is in a new form. It's called as matrix form of metformin. So when a patient takes glucovans, it is not a combined release of both metformin and glibenclamide. It's only glibenclamide which goes into the blood. It's a quick release of glibenclamide which controls the postprandial glucose. Metformin is released at a later stage to control the fasting plasma glucose. So one tab, you are controlling fasting and postprandial with equal efficacy rates. And many people have many times asked what exactly is the difference of a regular glibenclamide and the glibenclamide in glucovans. To make it very short, the glibenclamide in glucovans reaches the peak concentration in 2.5 hours, whereas a normal glibenclamide takes 4 hours to reach the peak concentration. So the benefit of reaching the peak at 2.5 hours is that this will match with the postprandial hyperglycemia, because maximum hyperglycemia is seen around 2.5 hours after the food. So this glibenclamide reaches the peak at the same time, bringing down the postprandial glucose with the maximum efficacy rates. Whereas the regular glibenclamide is unable to do that because it reaches the peak during the fasting phase to cause hypoglycemias. So to a great extent, we could prevent the problem of hypoglycemia in glucovans with this manipulation of the pharmacokinetic profile. So the net result, hypoglycemia is very, very less with glucovans. Metformin's pharmacokinetic profile does not have any change, it's the same thing. And these are the benefits of the tablet technology: excellent control over fasting and postprandial with the least incidence of hypoglycemia. One more thing, this drug probably is the only anti-diabetic which can be taken with the food. So patients are not confused what to take before the meal, what is to be taken after the meal. They can take one tablet of glucovans with the meal. So few missed doses, and it's very convenient for the patients. Talking about the efficacy part of glucovans, controls insulin resistance with metformin and impaired insulin secretion with glibenclamide. Very complementary mechanisms of action. These are the targets set by American Diabetes Association and International Diabetes Federation, as everyone knows. By using glucovans, you can reach these targets very easily, especially the HbA1c target of less than 7%. Many clinical trials have proved this point. The patients who had been on monotherapies in the past and who were not controlled, when you shift them to glucovans, 75 out of 100 patients will reach the targeted HbA1c. 75% is the success rate in the patients who failed with previous drugs. In the sulfonylurea failed patients, the drug brings down the HbA1c levels to the required normal. And this is one very interesting data I thought of showing it to you. It is US retrospective analysis. It compares glucovans with the same components given separately for a period of 6 months. And you can see that the HbA1c reduction with glucovans is 1.3% extra than what the same components did separately. So the drug is more powerful. You can use it in low doses to gain the control what you have been getting with high doses of separate drugs. Low doses can be used with glucovans. Comparisons, I don't want to go into the details at all. Glucovans is being compared with metformin-based combinations. I mean metformin glimepiride, metformin rosiglitazone, but the HbA1c reduction from the baseline is the best with glucovans. Even glucovans, when you compare with sulfonylurea-based combinations, I mean sulfonylurea, metformin, sulfonylurea, rosiglitazone, HbA1c reduction is the best with glucovans. It is durable therapy. The sugar levels are tightly maintained for a long period of time. Coming to the safety aspect, as I mentioned earlier, hypoglycemia is very rare. Very, very interesting slide here. Glucovans is compared with the contemporary drugs, glimepiride and repaglenide, which are commonly used ones. Please take a look here, doctors. Hypoglycemia is the least with glucovans. Absolutely safe. No need of any dose titrations in the patients even above the age of 65. Even gastrointestinal side effects are very rare compared to regular metformin. Weight regulation is just like any other sulfonylurea, but much better than glitazones and meglitinides. Coming to the last topic, compliance. Very interesting slide, I thought of just putting it. It's the results of a particular study carried out in the UK called as DART study. They analyzed the non-compliance problems of diabetes patients. Results are shocking. They found that 87% of the patients diabetic patients in UK are non-compliant. 2 days in a week, they forget to take medications, or in other words, they call medication holidays. The reason? Polypharmacy. Maybe one of the examples I've given over here, a patient takes, apart from anti-diabetic drugs, beta blockers, maybe ACE inhibitors, maybe aspirin, so the number of tablets is very high. Lesser the number of tablets, the better the compliance is going to be. Glucovans helps you to do that. You can reduce the number of tablets with glucovans instead of giving two drugs separately, metformin and sulfonylurea being given separately. Glucovans can be given. Two strengths are available. 500 by 2.5 is the lowest strength, and 500 by 5 mg is the highest strength. These are the indications. It's not a first-line therapy. It's a pure second-line therapy. For the patients who were on some drugs and not controlled, glucovans can be used. The patients who were on monotherapy and uncontrolled can be shifted to glucovans 500 by 5, 1 tab. The patients who were on two drugs can be shifted to 500 by 2.5, 2 times a day, or in some cases, depending on your priority, it can be started with even 500 by 5. But the maximum dose is up to 4 tablets of 500 by 5. So just to summarize, these are the key concepts of what I have presented right now. It's not a normal drug, it's an ATT, advanced tablet technology-based drug, more efficacious than metformin plus any sulfonylurea. Whatever is the sulfonylurea, they all can be shifted to glucovans. Excellent control over fasting, postprandial and HbA1c rates, with the least incidence of hypoglycemia and gastric disturbances. Excellent compliance rates, very moderate weight gain, and the dosage is very flexible because you have 2 doses available. You can play in the way you want with it. So, unsurpassed diabetes control is made simple with the new drug, glucovans. Thank you very much for the opportunity given to present.
Thank you very much. We have had this nice presentation, and what we learn in years, you summarize it in 1 hour. And this is also, and we enjoy it really, and I think we didn't get bored.
It was a Concorde flight rather than any. It was very fast.
Yes, okay. Thank you.
No, you can thank them. I will give one information.
Okay, also we thank our sponsor, the Merck, for sponsoring these lectures and Glucovan's presentation. Thank you very much.
Yes, there is only one thing I want to say, that now everybody knows that we are having these Johns Hopkins lectures, and the next year we have to send them the topics. So everybody is requested, if they have any interesting idea or some interesting topic, to give it to Marjan, so that we will facilitate and make the booking for next year, for 2006. So please, whosoever has interesting topic, please contact Marjan. And thank you very much for that.
Thank you very much.